going to cover for today. So just share some post-implementation updates, revisit the case rate trigger criteria, review claims payment resources, review some encounter form reporting, preview provider quality reports, and just answer questions that you have that are outstanding. And we can jump right in. So just a bit of a timeline about the launch. So we are really excited about the launch that happened at the beginning of January. So the maternity bundle has been a long work in progress for the state, starting back in 2020, and then through a lot of work and with the help of many of you, we've now launched the maternity bundle and are going to be looking for feedback and iterations on it in this first year. So we've did in 2024, we did a lot of engagement. I know many of you had joined, and some of you are probably new to this, who are just learning about it, but we are looking to continue to engage thoughtfully with many of you and hear your feedback about this program. So all to say, we are extremely excited to be at this point. Next slide. So just a few program updates. So far, we're very proud and really excited to tell you that there's been no technical issues to date. And we've been really working with providers to make sure they're feeling as supported. And many of you are representing provider practices, feeling as supported as possible. Obviously, nothing ever goes perfect. And we recognize that, but we are very pleased with what we've been able to do in this first few days of February and the first month of January. So just a few highlights. So 26 practices have transitioned into the program. We've paid out 887 case rates to date in this first payment cycle. It's just gone out. And the CHNCT provider engagement service team has been engaging with provider practices and their representatives to help support the launch and questions that come up. And some of those common topics included how do you sign up for the secure provider portal, about the encounter form, which will come up today, and then trigger event criteria and other billing scenarios. And so there's been opportunities. We've done a bunch of one-on-ones to help answer questions and help provide technical assistance. So, and you'll see the email there at the bottom to how do you get in touch with the provider engagement service team there. So maternity bundle questions at chnct.org. So please make sure to note that, or if you know who your provider engagement service representative is, you can also reach out to them directly. All right, next slide. So kind of now that we've launched, what are we focusing on at DSS? So we envision, similar to this, ongoing provider engagement, program monitoring, reporting, and continuous program improvement to really help make the program successful over time. And so that looks like stakeholder engagement, so opportunities like today. Also, as I mentioned, that one-on-one engagement as needed, reporting out to the legislative bodies and other agencies that might be interested in this, as well as other community and provider stakeholders who are interested in the success of this program. We'll be monitoring program reporting. So we're going to be kind of tracking certain measures about access and utilization, and so that will be upcoming. There'll be provider reporting as well, where we'll have timely data on quality and cost performance to let providers know how they're performing. Again, that this is part of this continuous iterative process where we'll give feedback and we'll get feedback on that feedback so we can continue to make it more effective. And then we'll be looking to make program refinements. So adjusting the program over time to make it more successful, making sure it's meeting the needs and goals of the program. So I'll pass it over, I think, to Tiffany at this time to take us on to the next part.
Thanks, Brad. As he mentioned, some of the common topics we received from providers to date have been questions around billing the trigger events and different billing scenarios. So just wanted to start by re-reviewing some of the guidance we've been providing. At the start of this program, at the beginning of the year, practices are eligible to bill and initiate case rate payments for second trimester patients. In order to qualify for your case rate payment, there's going to be 4 different criteria that need to be met. The first one's pretty automatic. You're enrolled in this program and if you're performing 30 or more births per year. The second one, that might be a change for practices depending on prior billing experience. would be submitting a claim with trigger event codes. So that's going to be your trigger diagnosis codes. Those are listed in the code list online at the DSS website. And then there are also specific E&M codes that need to be accompanying those trigger codes. In addition, we request that practices submit with a qualifying place of service location. So 11 for office place of service, 19 for off-campus outpatient hospital, or 22 for on-campus outpatient hospital. And finally, practices also need to bill under the qualifying maternity bundle specialty type, which include general OB as well as the subspecialty MFM, maternal fetal medicine, certified nurse midwife, obstetric nurse practitioner, and women's health nurse practitioner. And as a reminder, in response to provider feedback, DSS for the first quarter of this program from January 1st to March 31st is only allowing providers to trigger case rate payments in the second trimester for second trimester patients. So that means providers can start looking at patients who started their pregnancies as early as July 1st, 2024. Any patients who are basically in their second trimester from the start of this program are eligible to be initiated into this program by billing the case rate trigger event criteria. And so eventually in April 1st, you'll be able to start billing trigger events for patients in their second trimester, third trimester, and postpartum patients to initiate case rate payments. Moving on to a couple of questions that we received. One of the first ones we received early on is, should providers be billing E&M codes with a $0 charge? The answer to this is no. We actually expect practices to continue billing their usual and customary charges. In terms of how, when we've mentioned before, when you submit your trigger event claim, you'll receive a $0 payment. That's going to happen automatically on the back end when DSS processes your claims, but you should still continue to submit your usual and customary charges. The next question, once we submit the case rate payment, should we continue to submit claims for other prenatal visits or other postpartum visits? Yes, DSS's recommendation is for practices to submit and bill all claims to document the services that are provided to their member during the episode. This is going to help guarantee that you guys are maintaining your practice attribution for the episode. It's hard to know when patients are going to different providers, so this is just best practice to make sure you guys are always raising your hand to claim accountability for the episode. And B, in the future, when we make changes to the rates, it's going to be helpful to have a documentation of the services that you've provided so we can pull that into when we're looking at your historic claims expense. The third question, will there be any penalties on the case rate if the trigger event is not submitted by a doctor? No, as mentioned, there's a wide variety of maternity bundle specialty types that are accepted in this program. That includes advanced practice, registered nurse, certified nurse midwife, nurse practitioner. They can all submit the case rate payment and receive the full amount. And then last one, do we only get case rate payments in the postpartum period by submitting trigger events? So generally the way attribution and case rate payments work is that if you submit the trigger event, in theory, your case rate will continue in the following months, assuming you're the accountable provider. So by that logic, if you were attributed for patient care prior to delivery, you should automatically receive the case rate payment in the postpartum period. However, with that being said, because of, not being able to confirm patient attribution, as if another practice sees the patient before you do, DSS is generally recommending that practices still submit to meet the trigger event criteria when possible to maintain that episode attribution. So that would be including in that postpartum period after the delivery. So next we'll move into some logistics about what to expect for your first case rate payment, which should be happening just in this first payment cycle. So once you've submitted your claim with your trigger event criteria, those case rate payments are going to be identified and generated at the end of the month. Subsequently, expenditures will then be included in the existing semi-monthly remittance advice and 835 in the first claimant cycle of the month. In addition, in response to provider requests, DSS is also providing a supplemental payment report, which can be found in your secure provider portal. It's going to be available to all providers under the accountable TIN, and it's going to contain different information to support your ability to attribute the TIN level payments among your different providers and practices. So just to walk through a quick claims example, if you see a patient for care they're in their second trimester, let's say they come in January. In February, you're going to submit their claim for that January date of service with the trigger event criteria. So that January date of service trigger claim is automatically going to zero pay when it comes to DSS for processing. And then case rate payments for the month of January and February are going to be generated at the end of the month in February. You'll then see your case rate payment for both January and February in the first payment cycle in March. And then should you continue to be the attributed provider in the subsequent month, your case rate payment will continue. Again, recommending if you're able to meet the trigger event criteria to continue to submit those bills just to make sure you're maintaining your attribution during the episode. We wanted to highlight a couple of new resources that DSS had posted on the website. So already we've posted a sample 835 file. In addition, in response to provider feedback, we also posted an 835 and paper RA examples to show what those will look like for a zero paid claim, and also what the paper RA will look like when you receive your case rate payments. You'll also be able to get a sample test file of the supplemental payment report so you can see what information is coming through in those reports from your provider portal. And next, we're going to get into encounter form reporting. So as a reminder of the program's 10 quality measures, there are 5 pay-for-reporting measures, 2 of which, contraception and preterm birth, are going to be sourced from adjudicated claims data. There are then 3 measures that are going to require pay-for-reporting data submissions through the encounter form, which we tried to model similarly to the OBP4P program if your practice was participating in that. So the 3 measures that are going to be included in the encounter form are going to be doula utilization if your practice is receiving the doula add-on payment, and then breastfeeding and behavioral risk assessment. I'll note quickly again, if you are receiving the case rate payment, the doula utilization measure is going to be required for 100% as a threshold for meeting that reporting requirement. And then the breastfeeding and behavioral health risk assessments are going to require a 90% encounter form submission threshold to meet that reporting requirement. A little bit more guidance around what's expected for encounter form reporting. So the encounter form is really going to be helpful for practices to fulfill the pay-for-reporting measure requirements for those 3 measures we just talked about. And then B, it's also going to provide some helpful information that's necessary as part of the doula true-up process. So in terms of where you can access the encounter forms and how you can fill them out, those can be found on your Husky Health Secure Provider portal, specifically in the Maternity Bundle tab. When should you be submitting these encounter forms? In order to be considered for the program years measure calculations during reconciliation, we're encouraging encounters forms to be submitted within 30 days after the end of the birthing person's postpartum period. We also wanted to highlight in terms of workflow for your practice when you're thinking about filling these out, there is an option to partially complete and save in progress forms. So you can continue to submit information throughout the course of the pregnancy. You don't have to wait just the postpartum period if that's easier for your practice. But we will note that incomplete forms or saved forms are not going to be counted for the pay for reporting requirement. So make sure you're truly submitting them in their completed state to make sure it counts for hitting that requirement. And then member submission requirements. So who should you be submitting for? Because attribution can change based on multi-practice billing, DSS recommends that your practice submits the encounter form for all patients that you've received a case rate payment for. You can identify which patients have received a case rate payment for through that supplemental payment report, which can be found on the provider portal. And then in terms of the role that the provider may perform during the journey of the patient's care, DSS recognizes that providers might not have all the information that's requested of the encounter form. For example, if you're providing consultative care. So for these instances, DSS recommends that you still complete the encounter form, but you can use the NA answer option to bypass questions that you don't have the information on. And I will pause real quick. I see a hand from Patricia.
Hello. What my provider wanted to ask if DSS has taken consideration the forms. I guess he took a look at it today, and it seems very complex. The filling out these forms. Was this taking consideration that it looks like a nurse or anybody else cannot be filling out these forms. They all have to be filled out by the actual provider. Is that what this was a requirement when this form was put into place?
No, there shouldn't be a requirement that it has to be a physician or other provider. Other individuals in the practice are able to submit that information, so it does not necessarily need to be the provider that is filling it out. For example, in the existing OBP for P program, most providers have not been filling that out. So you've participated in that before. That's been the case where it's based off of documentation that's usually in the clinical electronic medical record or in other record keeping systems.
So all the information should be like on the first, it looks like it requires information early stages of antepartum and then after, so it has to be like compiled information be submitted within this form. Is just throughout the care of the patient. It's not something so somebody has to sit down, review the records, and it looks like it's a lot of information. What he was asking if DSS took time to like calculate payment, the fees that are getting paid. This is a lot of administrative work. If that was taken consideration, I haven't seen the form. He has, and he believes it's very complex for a nurse to be just a nurse. I believe he believes that a physician needs to be involved as well.
Yeah, it's a good question. We really did try to model it off of our existing structure that we've used for OBP for P for years. So that's our existing pay for performance program that we've used for an extended period of time. And so in many ways it's modeled off of that with the, not necessarily requiring the provider to fill it out. It should be based off of the existing records that should be pullable for the most part. Again, I think as Tiffany mentioned, there's going to be sometimes when it's a NA because it's a consultative provider who didn't provide this, or that those services weren't rendered as part of the care delivery. For example, doula services have not been submitted, so that would be not applicable. It maybe at another time Tiffany, I don't know if you want to add anything else, but we could review that in further detail on a follow-up potentially.
Yeah, that would be great. Thank you.
Yeah, and I just wanted to know, I think for using the NA option, I think that's going to require some updates on DSS's end to make sure that's included in some of the prenatal questions. But there won't be any penalties if you do the NA option. And so also, if you would like to view a copy of the encounter form, we do have an example on the DSS website that you can view, and we'll have that kind of linked in some of the resource slides coming up.
Thank you.
Tiffany, the other question is, should we be holding, from Katie, should there be holding claims to the end of the month, or is it appropriate to submit claims with a trigger event when the patient is seen? Definitely appropriate to submit the claims as soon as is reasonable with the trigger event. No need to hold those claims until any period of time.
Great, thanks, Brad. So a couple more FAQs related to encounter form reporting. The first is how should we handle multiple births? So you only need to submit one encounter form per delivery event, which can be a singleton delivery or a multiple birth delivery. Generally, all of the questions on the encounter form relate and apply to the single birthing person, and responses shouldn't differ or don't have to differ based on multiple births. Next question, should we submit an encounter form for live births? So while measures are calculated based on the rate of services provided to the total number of live birth deliveries, we would still like for you to submit encounter forms for all patients that you've received a case rate payment for, even in the event of stillborn or fetal demise. This is going to help support the doula true-up process. A couple clarifying questions on what was meant by some of the screening questions on the encounter form. So for substance use, does this include alcohol? Yes, that includes drug use and alcohol. For the tobacco screening question, does that include tobacco, e-cigarettes, vaping, or just tobacco only? That's going to include all three of those. So tobacco, traditional tobacco products, e-cigarettes, and vapes, as part of this following the CDC definition. And then if a baby is being breastfed from a bottle or a donor, does this count as breastfeeding? This question is really specific to birthing person to baby contact breastfeeding. So I don't believe that would count as breastfeeding. All right, and now we will get into provider quality reports. So I'm going to pass the reins over to Sean, I believe.
Yep. Hello, good afternoon, everyone. So we just wanted to give you a preview. Some of this will look familiar to you, but in addition to the reporting measures that Tiffany mentioned a little while ago, these quarterly dashboards will also include performance measures. We are anticipating that each of your practices will receive your individual data on a quarterly basis, with that first quarter coming to you in April. As we look at this information quarter over quarter, you can expect to see the numbers and the data set increasing, because we will be doing year to date by quarter. So just as a caution, and we have this statement on the documents as well, that initially the data from the first quarter, possibly the second quarter, will be limited as the data builds over time. I do also want to note that in the first quarter, it will not include the 3 of the reporting measures that are generated from the encounter form, only because we're expecting that to come in more slowly. So you should expect to see those additional 3 reporting measures from the encounter form by the second quarter. These will come to you via email from your CHN provider engagement services representative that you currently work with. And in order to kind of help support you as these reports come to you, we're planning to host a provider forum in April to talk more about understanding the quarterly quality reports. In the meantime, as you review those, if you do have questions or want more guidance, you don't have to wait for that opportunity. You can email this new maternity bundle PES email that you see on the screen and in the PowerPoint, or contact your provider engagement services representative, and they will be the link and coordinator to help really get you the answers and support you need in reviewing and interpreting that information. So if you can go to the next slide, please. So what you will be receiving in your quarterly report, you'll receive a page with your performance measure reports, and they'll be displayed similar to how you're seeing this screen. As I noted a moment ago, we do have this identifier to caution you that the quarterly data updates may have low case numbers, and that can affect the measurement. And it would appear as if they're not meeting the thresholds, but we want to remind you that the exact quality scores will be produced annually. So these quarterly visuals and representation of where you are against the threshold, don't be too worried or be too concerned, because this is done annually, because we know quarter by quarter, the size of the data set will likely not be sufficient, especially in this first year. Then if you go to the next slide, you will also receive a similar representation of data on your reporting measures. And as Tiffany said earlier, for the three measures, the doula utilization, breastfeeding, and behavioral health risk assessment, those will be coming from the encounter form and are expected to be included in this report starting in the second quarter. And I also want to note that if you are a practice in which you've opted out of doula, that information and dial and so forth would not be on your report since you had opted out of that measure. In addition to these visual representations of your data, you will also receive every quarter a description of each measure and the specifications of those measures. So you have that available at your fingertips with your report out. And you will also receive, which we've shared in previous PowerPoints, the overview information on how your performance and reporting measures feed into the annual reconciliation calculation. So that will come as a package for you every quarter. All right, I think I'm just looking to see if there are any hands raised. I don't think there are. So with that, I will give it back to you, Tiffany.
Great, thanks, Sean.
Mhm.
So just wanted to show a couple of the different program resources that DSS has created for providers. I will note the ones highlighted in yellow are kind of the more updated or the newer resources. So the program FAQ, we've been updating that as we've received provider questions. So keeping that up to date. And then the code list, we just did a silly renumbering of that one. So those are going to be posted. I think it's still in progress, but those are going to be posted relatively soon. We do have the 835 and paper RA examples, as well as the supplemental payment test file online already for you guys to review. So lots of resources available. And as Sean and Brad have mentioned, if questions do come up, if you'd like to request a one-on-one meeting, you're welcome to email the PES Maternity Bundle email on this page, or contact your designated PES rep. So with that, we can get into questions if folks want to enter them into the chat or just raise their hand and unmute. Hi, Kimberly.
Hi there, how are you? I had a quick question about the MFMs completing the encounter forms. So for those MFMs that are consultative in nature, how will they know? I guess what I'm trying to say is many times they don't know where the patient will deliver or if they've delivered or whether they've been, I guess, qualified for bundle inclusion. Is there any mechanism in the portal to help facilitate the encounter form being filled out, like a list of patient names that are attributed or any other report that they might be able to pull?
It's a really good question. I think, well, let me pause and see if anybody else on the team wants to chime in before I say we'll just get back to you on that. But Tiffany or others want to chime in with any of the thoughts.
No, I think, yeah, we can certainly take that back. It might be challenging to create a list of, patients in that sense, just because attribution can change pretty quickly on a monthly basis based on when providers are submitting claims for the patient, but we can certainly take that back.
Okay, perfect. Yeah, these providers would only receive probably one case rate payment because they fall under the hospital TIN with a local OBGYN practice. but they wouldn't necessarily be attributed in an ongoing way. So I'll hang tight for more.
This is Kim. We did get a question in the chat. Does the trigger code have to be listed as primary?
Kim, sorry, as listed as primary code on the claim, or is that the question?
Does the trigger code have to be listed as primary?
This is
So-
Sandy. I'm assuming that that they're asking about the diagnosis code being the primary diagnosis code, and no, it does not have to be the primary diagnosis code.
Thanks, Andy.
I also received a question in the chat. So I was wondering, when a patient in her second trimester comes in on January 1st, do we start the trigger claim? Yes, you can start billing trigger claims for patients in their second trimester as soon as now, or as soon as 1/1 if they came in 1/1/25. And you can continue to submit that on an ongoing basis. Patricia?
Be sure you're on mute if you were going to ask a question.
I'm sorry, I was talking. Just to clarify, so all the ultrasounds listed on the bundle code list will not be paid out until the end of the month or something like that, right? We can still bill them out as normal, but then it would only be captured as a payment at the end of whatever the time pay period is for that month.
You mean for specific ultrasounds that are listed under the code lists?
Yeah,
So, and if you mean if you only are providing those services, or if you're doing that in addition, you mean that you're doing a visit, an E&M code, and then you're also doing ultrasound?
yeah, so if it's a trigger code, well, we won't be doing EM code unless we're triggering. So let's say I do trigger, I do one of these ultrasounds. So these are part of the bundle. There's no separate payment be sent to us until the end of, until the end of the month, or is it the end of
Yes.
the delivery?
No, it'd be the end of the, so any of those codes that are listed under the included under the case rate, as soon as you initiate that case rate by having a triggering event, those other codes that are included then would be zero pay. They wouldn't be paid. But they're considered underneath that case rate that you're receiving. And so again, just as a reminder, that case rate is made up of historical billing patterns particular to your practice that would include those codes, like those ultrasounds, already baked into that case rate.
Okay, thank you for clarifying.
One question from the Q&A: how do we bill for a patient when they become inactive during their pregnancy? By inactive, I'm going to assume, maybe there is a fetal demise, stillborn, or miscarriage, something happened. Unfortunately, I think in those events, you would still bill as normal. And when we see that a fetal demise, stillborn, elective termination happens, those codes are gonna trigger the case rate payment to end. And you won't receive a lapse in coverage. Brad or Sandy, looking to you guys for if the patient has a lapse in coverage during their pregnancy.
Sandy, do you have any want to weigh in on that?
Well, if somebody's eligible for pregnancy related, because they're pregnant, we don't usually disenroll them. I mean, they're being enrolled in the coverage group for pregnancy, so I mean, if they're not eligible, if for some reason they're not eligible, they moved out of state, then I don't know, then we won't pay a claim if they're not eligible, but I don't think that we would be disenrolling somebody once they're pregnant because the pregnancy coverage is specific for pregnant women.
And I wonder if maybe if there's a third party, and they otherwise lose access to Medicaid for, of course, it is unusual, like you said, Sandy, for that to occur.
Yeah,
Go ahead.
we wouldn't disenroll because they have other insurance either. They would still be active.
And if there's any particular follow-up about specific examples, feel free to throw it in the Q&A or raise your hand.
One other question came in. Will hospitals with the case rate need to submit an encounter form with patients seen in labor and delivery triage as an outpatient?
If you're it might be easiest to answer, like if you are have a TIN that includes outpatient providers, and again, thinking about like, has the case rate been triggered by the TIN? So if you're receiving case rate payments underneath the TIN, then the answer is yes, should be submitting encounter forms. If you're a provider that's providing a service that's still fee for service, so maybe there's a delivery done and a case rate payment hasn't been started, so you're a covering provider in the hospital, for example, that wouldn't initiate a case rate payment. So for example, if Tiffany is a OBGYN and works for a health system and that does receive a case rate, and a patient comes in that's a Medicaid member, but has been receiving care elsewhere, but only comes in for delivery, and Tiffany performs the delivery services and bills those, that is not a triggering event and would still get paid professionally as a fee for service. Again, that's underneath that specific TIN. So Tiffany, any or others want to chime in to make sure I'm providing a useful example?
No, that made sense to me.
And feel free to follow up if that didn't make sense, whoever put that in. So please feel free to. For one more minute, if no other questions, we'll wrap up.
I received a question. Please clarify when encounter forms are to be submitted, or only the pay for service items for all. So let me just start by clarifying when encounter forms should be submitted. That should happen 30 days after the 90-day postpartum period. And that's specifically for the 3 pay for reporting quality measures. There's 2 other pay for reporting measures that are going to happen automatically when you submit your claims. is the access to the case rate supplemental report on the DSS CMAP website or the Husky Health portal. Sandy, do you want to confirm that one?
Okay, what was the document again?
Is the supplemental case rate report on the CMAP website or Husky Health portal? I can try to go back. It'll be found at this link at www.ctdssmap.com.
Yeah, so yes, they have to log into their provider portal.
If we haven't put that up on the other, on the DSS, maybe we try to put something there and we can circle back around that just to make sure it's, people can find the link if they stumble upon the main DSS maternity bundle website.
Good idea. Patricia? And you're muted again in case you're talking.
Thank you for letting me know. Under the maternity bundle code list again, at the bottom where page 32, there's some BY49ZZZ codes. Do I have to use those codes in anywhere? Any of the billing? Do I have to add that when I do the first trimester on single versus multiple gestation? Do you need that as a identifier in any of the claims? It's a BY49ZZZ or BY4BZZZ. When do I use those codes?
I don't have that up in front of me. I don't know if anybody else has the list up for that to be specific.
Okay, it's under the bundle codes. I don't know if it's just reporting codes that you like us to use. It's page 32 of the 72. Where all the CPT codes and diagnosis codes are in there. There's some of these types of codes as extraction of products of conception 10D07Z4. Do we have to use this at all? That's all I want to know. It's mixed in with the CPT codes of the bundle.
Let's see if I have it.
As a
Does anybody else by any chance on the team have up our case rate, what's included? It sounds like
It says delivery of products of conceptual external approach.
I'm pulling it up now. These are the codes you're referring to, right?
Yes, yes. When do I use them?
So these are included in the reconciliation code list. So if these are included, those codes and the associated costs will be factored into the shared savings calculation.
So that's something I would have to report claim base?
it would be a claim that you'd normally submit. So if you were doing that, and just as a high level, how we've kind of tried to structure this, I'll get to the specific in just a second, is just, we want to somewhat use the existing structure of billing in some component, right? E&M codes are very familiar. The diagnosis codes that the trigger codes are based off of are relatively familiar in terms of trimester. And then these other codes here would be the ones that would get included for the reconciliation. So as long as you're going about the service delivery that you normally would, so say you're doing this ultrasound of the first trimester single fetus and you build that as a CPT code, that would then get, whether it's included under the case rate or not, all the codes that are listed here would then get pulled into the total for the reconciliation where we decide if there's shared savings. So for example, Tiffany, does that sound right? And Grace, if you want to jump in, make sure I'm getting it right from your standpoint too.
No, Dr. I think that's spot on. Yes, so these codes will only be included in the share saving calculation when we consider what is part of the episode cost. So if you bill it normally with your first trimester, second trimester, or third trimester services, then you keep billing them. Otherwise, just, you don't have to bill them.
I don't, that's what I want to make sure I don't have to use them if I am use one of the codes that are listed. If I'm using a trigger code and a trigger diagnosis for this encounter of the first trimester, I do not need to use any of these codes.
That's
Okay.
correct.
Yeah, okay.
And I just want to say that if these codes came in on a claim instead of a procedure code, we would deny it because I'm not sure if these are a different, they're not regular CPT or HCPC codes, so we don't even have them in our system. I don't know if that's where they were intended to be put in as a procedure code, but I think there's like other procedure codes out there, procedure code lists, SNOMED or something like that. I'm not sure if that's what these are, but we don't have them in our system even.
Thanks for flagging those, Sandy and Patricia. We can take that back if we need to potentially remove them from this code list in that case.
Yeah, that's a little confusing. I'm just trying to capture all this information that's here that I don't want to be 6 months down the road and I'm missing any steps since this is new for us and then I get not paid accordingly to what we're expecting, then the physicians decide not to participate in Medicaid. So I want to make sure I want to do the right thing and putting in all the codes required to capture all the services we're doing. So I appreciate clarification on this list to give us what we have, what is that you were expecting us to use? Because I can be very creative with this list and assume I need to put that on it because it's here. But if it's not required, then I will make a note of that.
And we have a couple different lists, you'll notice, Patricia, and just to say thank you, we appreciate your feedback and, we're trying to put this information in a way that makes sense. And so there are a couple different sets of codes. You have your existing CPT codes that help with the triggering and along with the diagnosis. And then you have all of these. So what Tiffany has pulled up there, the trigger codes or the diagnosis codes that will help trigger the event. And then the other codes we're looking at are kind of all the codes that are included under the shared savings, just so you know what's included as we're thinking about the total cost of care for the maternity bundle itself. And especially if you're less familiar with this can get very technical. And so we understand that and we appreciate the questions and allowing us to help make it as clear as we can, understanding it's a relatively complicated structure. We tried to make it as simple as we could, but there's still a lot of complications anytime you build out a model like this.
Okay, a couple other questions came in the Q&A. So there's a request for more details on where the reports under the DSS map can be found. So I think we can take that back and follow up to provide more information there. If you want to send a chat to me or Brad with your email, and we can follow up specifically with you to give more guidance on where to find that. Next question, will the case rate reports be just for the previous month, or will there be a cumulative report also? Will there be a report available on all births that we're required to report on? Sandy, do you want to speak to I think this is referring to the supplemental case rate or supplemental provider reports, if that's going to be just the previous month or a cumulative report?
It will be just the previous month. It won't be cumulative. It'll be a report after each. We will be making the case rate payments in the first claim cycle of the month. So we just ran them in this past weekend's claim cycle. And then the report will include, it'll be a report of anybody you just received the case rate payment on. And then next month, it'll be the case rate payments that we made for February. And so on, but it will not be cumulative.
Thanks, Sandy. And I don't believe there's going to be a report for all the births that are required to report on. Like we mentioned, we would just kind of use that supplemental payment report, but we can take this back.
Hey, well, I think we'll post down this afternoon session. Thank you guys so much for the very helpful questions. We really do appreciate it. It helps provide us with some guidance and clarity about how we can be more clear with everybody. I just want to reiterate our appreciation for your engagement and being here. We know this is a relatively large shift for many of you trying to understand this. Some of you have been involved in this for a while. Some of you may not have been aware of this until more recently. And so we understand some of the challenges that you all are facing, and we definitely want to hear about them as well. And so we look forward to further engagement, and please do reach out. You have that contact information. We will be posting this deck, as well as posting a link to this discussion today on the CTDSS YouTube website, as well as the CT Maternity Bundle website as well for the documentation. So thank you all. Have a great day. On behalf of DSS, we really appreciate you being here, and we look forward to hearing from you.
Thank you.